Hi, this is Maksud Ahmed Lashkar, Assistant Professor, Faculty of Pharmaceutical Science, Assam Downtown University. So today I'm going to present here a topic that is pathophysiology of peptic ulcer. So we all know this peptic ulcer is a very common disease in most of the people in urban as well as in the rural area because of their lifestyle or maybe because of some drug consumption or daily habituates. Okay, so we will see first of all what is peptic ulcer, then we will go through the etiological prospects of peptic ulcer, then we will see the pathogenesis, how this peptic ulcer actually happens, then we will see the various diagnosis process of this peptic ulcer, followed by their complication and management. So first of all, peptic ulcer, it has been said that it can be defined as a lesion in the lining. Okay, is the lesion in the lining, that is of mucosa of the digestive tract. So typically in the stomach or duodenum, this peptic ulcer has been found. So actually it is caused by digestive action of pepsin and stomach acid, that is HCl and pepsin. This pepsin is an enzyme, so they have a role in our digestion. So basically whenever there is food, that time they will digest the food, and unless if there is no food available, that time they can cause some uh, other effect or alter effect that can later on leads to peptic ulcer. And so then the lesion may be subsequently occur into the lamina propria and submucosa, which ultimately may cause bleeding. So actually most of the peptic ulcer, they are either in duodenum or it may occur in stomach, and to a little certainty is there in the small intestine. Then we will see the etiology and risk factors of peptic ulcer. So etiology, generally like lifestyle. So the people who are habituated to smoking, then medication with NSAIDs, then acidic drinks, alcoholism. Okay, so these are the lifestyle based factors which may induce peptic ulcer. Then H. pylori infection. So this is the most common one, where 90% of people they have this bacterium, and uh, it actually passed from person to person. Then we will see the age. So it has been seen that in duodenal ulcer 30 to 40% and gastric ulcer over 50 years, this peptic ulcer can be uh, privileged. Then there are some related to gender. So duodenal ulcer are increasing in older women, and then other factors like genetic factor, then stress, and yeah, stress, but it can worsen without, but it may not be a cause. Then we will see the pathophysiology of peptic ulcer. So actually this peptic ulcer, actually it causes because of the imbalance between the aggressive factor as well as defensive factor. So here the aggressive factors are like H. pylori, then NSAIDs, then pepsin, bile acids, smoking and alcohol. That these are the things, it can be categorized under aggressive factors. So they causes the imbalance between the gastric acid secretion and gastroduodenal mucosal defense. Then second point here I have shown it, that mucosal injury or peptic ulcer thus occur when the balance between the aggressive factor and the defensive mechanism is disrupted. And lastly, the aggressive factors also may alter the mucosal defense by allowing the back diffusion of hydrogen ions and leading to the epithelial cell injury, ultimately may result into peptic ulcer. Then here I have shown some complication that is found in peptic ulcer. So the first one is hemorrhage, then perforation and narrowing and obstruction of pyloric. So hemorrhage, it has been said that blood vessel actually it get damages. It's because of erodes in the muscles or in the duodenal wall. Okay, so these blood vessels actually get damaged. Then perforation, so this ulcer also can erode through the entire wall of the stomach, and thereby bacteria and partially digested food they can spill into peritoneum and peritonitis. Then lastly, the narrowing and obstruction pyloric. So here actually swelling and scarring is the main thing which can cause the obstruction of food leaving stomach and may also cause repeated vomiting. Then we will see the diagnosis of this peptic ulcer. So peptic ulcer can be diagnosed by using the different techniques here. So the first is like endoscopic procedure, then upper gastrointestinal series, or maybe by urea breath testing. So these are the tests which can determine that whether a person is having this peptic ulcer or not. Then we will see the management of peptic ulcer. So the management actually, though we have said in etiology or risk factor, is so many times it's been related to our lifestyle. So we have to modify the lifestyle. Second thing, hyposecretory drugs. That means some drugs we can use for decreasing the secretion of stomach acid or enzymes, which actually was leading to the peptic ulcer as because of their excess secretion. So if we minimize their secretion, then it can be prevented. Then H. pylori eradication therapy followed by surgery. Then okay, so in lifestyle modification we can do things like we can discontinue the NSAIDs, though these NSAIDs like paracetamol, diclofenac sodium, so these are very dangerous for our stomach. Okay, and they can lead to the damage to the mucosal layer or innermost lining of the stomach. Then cessation of smoking, then alcohol cessation, then stress reduction. So these are the lifestyle modification. If we go through, then we can minimize the peptic ulcer in our body. Then hyposecretory drugs. So obviously there are some agents which can decrease the acid secretion in the stomach. Not only acid as well as their enzymes. For example, proton pump inhibitor, okay, like omeprazole, reviprazole, they will decrease the generation of proton, thereby cell production will be minimized. Then we can use directly the antacids. So these are nothing but bases, so they will neutralize the excess acid present in our stomach, followed by some H2 receptor antagonist. So histamine H2 receptor antagonists like ranitidine, famotidine and cimetidine. So these are the H2 antagonists. They can antagonize the histamine, thereby the acid production as well as stomach motility will be minimized. And then we can use some drug like prostaglandin analogs. So it has been seen that prostaglandin analog, they can, and this prostaglandin actually they have some role in maintaining the innermost layer of the stomach, that is mucosal layer. So Lastly, H. pylori eradication therapy. So this is also called as triple therapy. So here actually we can give a drug proton pump inhibitor. With that we will give two different antibiotics. So that combination of antibiotics may be like metronidazole as plus clarithromycin, or it may be like clarithromycin plus amoxicillin. So these kinds of management we can go through for our peptic ulcer. Okay, thank you.